Hi, everyone. My name is Diana Caragacianu, and I'm the Medical Director of the Breast Center at Milford Regional Medical Center. And I have with me the leader of the high-risk program at our center, Monique Burchard, NP. She will be introducing to you the breast cancer risk and risk management. The way we look at it is, 1 in 8 women have cancer, but 7 in 8 women are really worried about what their cancer risk is and what type of screening and detection modalities they should have. So Monique will go over all of that today. Thank you for joining us. Monique.
Thank you, Dr. Caragacianu. So today we're going to talk about breast cancer risk. So let's start with what is risk. In terms of health, risk is the possibility of a negative health consequence due to a specific event, disease, or condition. So risk factors increase a person's chances of developing a disease or having a negative health consequence. When we talk about breast cancer risk, there are several factors that increase a woman's chance of developing breast cancer. First and foremost, being female. Men do develop breast cancer, and we certainly see men in this clinic who have breast cancer. But it's important to know that only 1% of all breast cancers occur in men. The other 99% occur in women. So just by being a woman, you have an increased risk of developing breast cancer. If you've had a prior breast biopsy, your risk can increase. If you had proliferative breast disease, which is benign findings of breast lesions that grow, but especially if there were abnormal findings such as atypical ductal hyperplasia or lobular carcinoma in situ, those increase your risk significantly. Also, increasing age. The median age at diagnosis for breast cancer is 63 years old. But as you can see by this chart, although we do see women with breast cancer from their early 20s all the way through their 90s, most breast cancers occur in women between the ages of 55 and 74. So it's super important that people continue with their annual screening mammograms. Mutations in cancer genes also significantly increase your risk of developing breast cancer. And when we do or we have genetic testing done, there are 9 well-established genes that we look at that increase your risk of developing breast cancer. Most people have heard of the BRCA1 and BRCA2 genes, but there are others that are important as well, especially this PALB2, which has become much more important over the last couple of years as we've learned more about it. And in many circles, they're referring to PALB2 as the BRCA3 gene. If we look at this handout, you can see that a woman without other risk factors who has a normal non-mutated BRCA gene has about a 12% chance over the course of her lifetime of developing breast cancer. BRCA2 mutated gene increases the risk to 45%. And a BRCA1 mutated gene increased the risk to 55 to 65%. And that is very significant when we're talking about risk of developing breast cancer. Other factors that increase breast cancer risk, well, having dense breast tissue on mammogram. We talked about this in our dense breast PowerPoint, but if you look at this picture, this is an extremely fatty breast on mammogram. The fat tissue shows as black and a cancer would show as white. So you can see in this picture, it would be relatively easy to pick out a cancer. As we move along the continuum of breast density, all the way over here to the extremely dense breast, there's a lot of white there, which is dense breast tissue, but cancer also shows up as white on mammogram. So not only is it harder to find a cancer in a dense breast, but dense breasts independently of that, have an increased risk of developing breast cancer. The length of time you're exposed to hormones also plays into your risk. Early menses before the age of 12, late menopause after the age of 55, or having no children or having your first child after the age of 31 increases your risk of developing breast cancer, and that's because of the length of time you're exposed to estrogen. Family history or personal history of breast or ovarian cancer also increase your risk of developing breast cancer, as does previous treatment with radiation therapy prior to the age of 30, such as what occurs when one is being treated for Hodgkin's lymphoma. So there are risk factors you can control. Most of those that we talked about before now are out of your control, or you don't know that they increase your risk until you've already waited till you were 31 to have a baby. So there are risk factors you can control. Physical inactivity increases your risk of all-cause cancer, and that can lead to obesity, which also is a risk factor for cancer, but obesity after menopause significantly increases your risk of developing breast cancer. The American Cancer Society used to say that we should limit our alcohol consumption, but in 2020, they came out with a statement stating that we should avoid alcohol completely if possible. And if not, then we should limit it to women 1 or less drinks per day. Combination hormonal replacement therapy for greater than 5 years also increases your risk of developing breast cancer. And of course, we know what you put into your body makes a difference. So your nutritional intake is important when it comes to cancer risk. Lots of fruits and vegetables are recommended, especially those with bright colors, whole grains, and limiting processed foods or processed meats and red meats.
This is so important, Monique. I think, you know, we see, both you and I see many patients that are so concerned about the risk, and many patients feel out of control. And certainly once a patient is diagnosed with cancer, they feel so out of control in their life, their choices, their treatments. And so one thing that is really modifiable are these risk factors, and they do make a big difference. So you know, a couple of really important studies that certainly changed, you know, how I approach nutrition is, you know, a couple of years ago, a study came out demonstrating that processed meats is linked to increased risk of breast cancer as well as colon cancer. And that really made a difference in how I, you know, what I eat and what I feed my daughter, my 8-year-old at the time, 5-year-old daughter. So, you know, it's so easy to do, you know, hamburgers, you know, hot dogs, you know, kind of processed meats. They're quick and easy, but it turns out they're really, really not healthy. So when someone asks me, you know, it's hard to change everything all at once, but I would choose a couple of things. And that one thing that I certainly changed for my family, and I recommend for our public to change is processed meat intake. And then in terms of alcohol consumption, that's a little harder. My culture, we drink a lot of wine. So I find it hard to part with that. But we, you know, a study from Dana-Farber a few years back demonstrated that, you know, excellent study, that more than 4 drinks a week resulted in higher risk of breast cancer. So that's what I use as a guide to tell patients is drink less than 4.
I think that's a good point. And one of the things I share with patients is that you do what you can in moderation. If we try to take on all of these roles as perfectly as possible, we're destined to fail because it's way too much to take on at one time. Exactly. So physical activity is recommended at 2.5 to 5 hours per week of moderate intensity activity. Well, if you're not exercising, starting with 15 minutes a day of just walking around the neighborhood is a big change. So I don't think that we should start by striving for the top. We should start by just making small changes and eventually getting there. One of the things that you said that really rings true is control. Take control of what you can. And what we see so much in patients after they develop disease is how they struggle with the loss of control of their health. And so this really is important to look at this and say, what can I control now?
Exactly.
So that I can avoid being in that situation.
Yes. Thank you. Thanks, Monique.
So overall risk, going back to that same thought process, most disease, including breast cancer, is thought to be due to multiple interacting factors. So focusing on those things that you can control can help to mitigate your risk. There is no one smoking gun. it's several factors that interact, because even people who have BRCA mutation, some go through their entire lives and they never develop a breast cancer. There are other factors that interact with those to make things happen. So who should have a risk assessment? What type of patient? Well, a woman who has a family history of breast or ovarian cancer should definitely have a risk assessment done. Women with dense breast tissue should have a risk assessment done. And women with a history of breast biopsy, especially if they had atypia or atypical cells found on their biopsy, should also have a risk assessment done. Any woman who has a question about whether she should have a risk assessment done should have a risk assessment. How do we calculate that risk? Well, there are several risk calculators, and some examples of those are the Gale model. The Gale model includes first-degree family members only. It doesn't ask for the age of their onset of breast cancer, and it doesn't include breast density. It's a good risk assessment, but it's one of several. The Klaus is another model out there, but the Klaus does not include any non-hereditary factors. Basically, it's only based on family history, so your personal history doesn't really play in there. And then there's the Tyrer-Cuzick, which I tend to prefer. The Tyrer-Cuzick includes family history, non-hereditary factors, and breast density. Each of these has strengths and weaknesses, and each works best on certain populations. We tend to use the Tyrer-Cuzick and the Gale in this clinic so that we can include personal and family history, reproductive and hormonal risks, as well as breast density. And I'll give you an example. This is a Tyrer-Cuzick risk assessment. I like this one because it includes many factors. It can, however, tend to overestimate your risk if you have dense breast tissue and more than just first-degree family members who've had breast cancer. So this woman, for example, a 40-year-old woman who started her period at 12 years old, 5'8", 175 pounds. She had her first child at 29 years old, no prior biopsies, and she's premenopausal. She has heterogeneously dense breasts, C density breasts, so those are on the denser side. And she has a family history of a mother with breast cancer at the age of 52 and a maternal grandmother with breast cancer at the age of 55. None have had genetic testing, and she has not used hormone replacement therapy. When we look at her risk assessment here, the average woman her age has a 12.9% chance of developing breast cancer. Her risk is calculated using this Tyrer-Cuzick model at 36.7%. That's a significant increase, and she would definitely fall into our high risk category. Anyone with a risk over 20% is considered to be at high risk. But that seems excessive. So I went on and calculated the same exact woman with the same information in the Gale model. And when I calculated her risk using the Gale model, which again does not include breast density, and it only includes first-degree family members, so only her mother, not her maternal grandmother, was included here, her risk only came to 18.8%. That's a big difference. So if we compare the two, 36.7% on the Tyrer-Cuzick, 18.8 on the Gale, if I average those two together, her overall lifetime risk comes to 27.75%. This is an example of how different these two can be and why we use two models to get a good average of your risk.
Yeah, thank you for showing that. I think that's really important because these calculators are not perfect. They're an excellent guide, and it does help us get MRIs certified by insurances for people that fall over 20%, but it can also induce some form of anxiety. So certainly when we calculate risk, we do inform the patient that especially Tyrer-Cuzick can overestimate the risk. So for someone that has just family history, like the patient that you presented, no atypical cells even, that person really isn't at 36 point something percent risk. They're certainly elevated more than 20%, but we normally articulate to the patient that it's not that high just to not have them worry about it. And I love what Monique does. I love the extra time that she takes to actually average it. This is actually quite frankly, more accurate than doing just one. So thank you for underscoring that.
Absolutely. So what are the screening recommendations if you're high risk? Well, if your lifetime risk comes out to 20% or higher, we recommend annual bilateral screening mammogram, annual screening breast MRI, annual clinical breast exam, as well as a recommendation to meet with a medical oncologist to discuss the option of risk-reducing medications, such as tamoxifen or viloxazine, which are selective estrogen receptor modulators. They block your estrogen so that it can decrease your risk of developing breast cancer. Risk based on genetic mutation. Part of your risk assessment when you come in with family history includes determining if you meet National Comprehensive Cancer Network criteria for genetic testing. And if you meet the NCCN guidelines for genetic testing, we refer you to the Department of Genetics for counseling and genetic testing. If you're found to have a genetic mutation, a pathogenic mutation, recommendations will be tailored specifically to you, to your personal situation based on NCCN guidelines, because they differ according to what gene and what mutation.
Absolutely. This is really helpful. I want to go back. Can we go back a little bit to the genetic screen? So, you know, we've had patients who get, in fact, you know, as Monique stated, patients have overall, all comers, about 12% risk of having a gene mutation. So it's not, you know, high in the regular population. Someone obviously who has heavy family history is higher, but when we do have someone who meets criteria for genetic testing and they get the testing and they end up being negative, sometimes I get this comment, oh, great, I have a negative gene mutation, I can't get cancer, or I'm at low risk of getting cancer.
I get that all the time too.
Yes, right. This is so important to understand that it's, you know, it's kind of like two branches of a tree, and genetic, even if genetics is negative, if a person has family history, they're still at high risk. And it may be if they have very heavy genetic family history and a negative genetic test, it may be that they have a gene that we just don't know what to test for. And this is also very important in terms of the gene testing. Currently, we do oftentimes we do panel testing to test for all those multiple genes that Monique has demonstrated. But they are separate entities. We absolutely, if someone meets criteria, have to test for genetic testing, because the risk, if one has a pathogenic mutation, is so much higher than if they have just family history. But if you have negative test and you have family history, it does not mean that you're now back at normal risk. Okay, so thank you again.
And the only time I see something a little different from that is if we know that their family history of cancer is tied to a genetic mutation, and then we test that patient and that patient doesn't have that specific mutation. And that's the only time I say your risk falls back down to that of the average person. Otherwise, if your family doesn't have the mutation and you don't have the mutation, your risk is still elevated because there's some familial component that we just don't know how to identify yet.
Exactly. Thank you.
So if you have risk factors, what do you do? Well, see a breast specialist for assessment of your personalized risk. Not everyone with increased risk will develop a breast cancer. You can take steps to improve your overall health to keep your risk from rising any higher than it is. But it's important to know that appropriate screening increases the chance of us finding a cancer in its early stages, and the early stages are when outcomes are optimized. Thank you for joining us today for our educational session on breast cancer risk. We hope you'll join us in the coming weeks to learn more about breast health. Please feel free to contact our office at 508-482-5439 for a consultation if you have any breast-related concerns.
Thank you,
Dr.
for joining us. Thanks, Monique.